Thank you again for joining us for tonight's presentation on neuromodulation devices for migraine. To disclose, Migraine Canada has had this event sponsored by Cephaly, and as well we have our other regular sponsors as well, which I'm showing on the screen. And how it's going to go tonight is I'm going to provide a introduction on Migraine Canada. I will then introduce Dr. Monsour. He will present on neuromodulation devices, and then after his presentation, we will get to your questions. I'm just letting in some more people that were in the lobby. Teams is funny. Okay, so Migraine Canada is a federally registered charity to support the nearly 5 million Canadians who do live with migraine and other headache disorders. And we do this through our 5 pillars, which are advocacy, awareness, education, research, and support. Tonight's presentation is the last 2025 presentation we have, so stay tuned for our 2026 schedule that will be posted. And just to let you all know that this webinar provides information and not medical advice. Please note that the information presented and discussed might not apply to your own medical situation, and always discuss your medical treatments with your own healthcare provider who knows your medical history. And now to introduce Dr. Danny Adel Monsour. He is a neurologist specializing in headache medicine and the director of the Axon Institute for Headache and Neurological Sciences in Oakville, Ontario. He completed his adult neurology residency and fellowship in headache medicine at the University of Toronto. Dr. Monsour serves as the consultant neurologist for the University Health Network's intracranial hypotension program and is an active member of the Ontario Headache Consortium, Canadian Headache Society, and American Headache Society. He also contributes to the Spinal CSF League Canada as a member of its medical advisory board. And with that, I'm going to stop sharing my screen and turn it over to Dr. Monsour.
Thank you, Kaylee, for that lovely introduction. I had no idea I'm going to be the last presentation for the year. My goodness.
Yeah.
Okay. Last but not least, I suppose.
Definitely.
Okay. Here we go. Everything look clear?
It does. Thank you.
Wonderful. All right. Welcome, everybody. Coast to coast to coast. This is awesome. So today I'm going to be talking about neuromodulation for migraine. So the concept behind these devices that you probably heard about that can help treat migraine both acutely and preventatively. And I'm going to be focusing a lot more, doing a deep dive on the ones available in Canada. I will cover some of the other ones not available in Canada, but certainly the ones that are accessible to us as providers to offer to you as patients are limited to a few. So the topic here is called the circuit breakers. These are my disclosures, none of which are actually relevant to this topic. I also wanted to mention that I know that Migraine Canada has a sponsorship from Cephaly, but I have no financial relationships with any of these device manufacturers, so completely unbiased, no conflict of interest on my end. I'm just going to present what's available for educational purposes only. It's intended to promote scientific understanding, does not constitute endorsement of any specific product, company, or commercial interest. So let's get started. We got 5 objectives we want to achieve today. 1, I want you to leave here understanding what neuromodulation is and how it's going to help you treat your migraines. 2, I want you to be able to recognize the main types of neuromodulation devices that are out there, how they work. I want you to also learn which devices are currently available in Canada and how to access them. So access is not limited to the just the new anti-CGRP agents or the oral medications, but access is also an issue when it comes to these devices too. I want you to be able to explore whether or not these devices are good for you, and also know what to expect in terms of treatment process, costs, and supports. So this is quite a crude picture, but to know where we are today is to understand where we came from. And where we came from as humans is not that appetizing. This is what's called trephination or trepanation. It's the oldest known surgical procedure, drilling or scraping a hole into the skull to release pressure. This was practiced as early as 7000 BCE across Peru, Egypt, Greece. It was thought to be able to release evil spirits and relieve head pain, epilepsy, and quote unquote pressure. Now, some skulls that were discovered showed bone regrowth. What did that mean? It means that individuals who received this quote unquote treatment actually survived. Now, whether or not they actually got symptom relief is unknown, but certainly it was something that has been repeated across the globe. So there was this humanity's earliest attempt to modulate the brain, though very imprecise and without much anesthesia, unfortunately. If you look at Eber's Papyrus, so this was basically a document found in Egypt, ancient Egypt, from around 1550 BC, and it's one of the earliest known medical documents with a list of hundreds of treatments for pain and disease. It blended early science with spiritual rituals. What you'll see here is a depiction of this ritual where a clay crocodile holding grain on the head bound with linen, symbolic remedy for headache. Now, if you can think of why would the ancient Egyptians want to put a clay crocodile or linen on somebody's head, or at least compress it or push on areas of the head. So let's think about what we do when we have a headache. You know, when I have a migraine, all I want to do is this. I kind of compress my temples, I compress my head to sort of provide this alternative stimulus. Well, they perhaps were doing the same. It's hard to say. And this was sort of a symbolic beginning of humanity's enduring quest to quiet down pain. And what I also provided here was a advertisement from 1920s showing how electricity was nature's chief restorer. They wanted to advertise the cure for nervous and chronic diseases without medicine. Certainly sounds very familiar. Electronic belts, they called them. Now, we don't use electronic belts nowadays, but modern neuromodulation continues this long, per human pursuit for treating pain, but it's now guided by science and electricity and magnetism. So this brings us to the need for neuromodulation. So why do we need this now? Why do we need this now in migraine management? Well, non-invasive devices are safe. They're alternatives to conventional pharmacologic therapy. I can attest to the fact that, many of my patients who try some of these oral treatments do endorse some systemic side effects some of the time. You may not know this, but in approximately upwards of 50% of people who use an oral triptan, for example, can have an adverse event of any sort. Be it from fatigue to some of the more classic triptan side effects where it's the tightness around the jaw and chest. So using something like neuromodulation could avoid these systemic side effects and suit patients who are intolerable to oral medications. Now, it's also ideal for special populations. There are folks who cannot be on triptans or Gepants or a lot of the oral medications we would like to try for migraine. And so these devices could be a solution. So this includes folks who are pregnant, and this can also include folks with other medical issues such as cardiovascular disease. So I keep saying this term neuromodulation, but do we know what it is? Well, let me define it for you. So it modulates central pain pathways via peripheral nervous tissue. So what does that mean? It basically means that we can transform how the brain is signaling pain, just stimulating the peripheral nervous system. So the peripheral nervous system is our conduit to the central nervous system, right? And so we can do this electrically, and I'll define what these acronyms stand for in a moment. And we can do it magnetically or a combined way. And so this is what neuromodulation does. It stimulates the peripheral nervous tissue, essentially, to modify how the central nervous system is modulating pain. And the desirable outcome here is we want to restore function and relieve symptoms of migraine. So this picture here shows a person who has a lot of money because they're using quite a bit of these devices, which are not cheap to say the least. But it just goes to show what parts of the peripheral nervous system these devices target. The ones that we'll focus on include transcutaneous supraorbital stimulation device, so the one that we see quite often, the cephalate device, the head-of-term device, and the extra or non-invasive vagal nerve stimulator called the gamma core sapphire. And there are a lot of other ones here, such as devices stimulating the vestibular system. We have the magnetic stimulator device on the back of the head, or the occiput. And you also saw that they have what's called the remote electrical neuromodulation device situated in the arm, and we'll talk about that in a moment. So what is the device landscape? So there are 6 sort of, let's say, overall technologies. There are more to come, but these are the main 6. And what I've done in this presentation is anything that's available in Canada will have a maple leaf next to it. So we have here the external trigeminal nerve stimulator in box A. We have a form of the external trigeminal nerve stimulator, which also uses transcutaneous electrical nerve stimulation, or TENS, in box B. Box C shows what's called the single pulse transcranial magnetic stimulation. D shows the non-invasive vagal nerve stimulator. E shows us the REN device, or the remote electrical neuromodulation device. And then box F shows us this combined occipital and trigeminal nerve stimulator. So it does both at the same time. So let's do a deep dive. Let's get into it. Let's begin with the ETNS, or the external trigeminal nerve stimulator. If we zoom in on this the individual with all of the devices, you can see that this TENS device is located just above the eyebrows. There are 2 available in Canada. So one is called Cephaly, and the other one's called Hedaterm. There's Hedaterm 1, which is the disposable one-time use, and then there's Hedaterm 2, which actually has the electrodes. And so let's go through this box. As you're going to see here, I've devised these tables that summarize everything pertaining to these devices in detail. And so the device names, as I said, are the ETNS. It uses a similar concept as TENS, right, or this transcutaneous electronic nerve stimulation, that targets 2 nerves. You have 2 nerves that run up your forehead here, supratrochlear nerve and supraorbital nerve. They go all the way up your forehead, all the way, sometimes upwards of halfway through the scalp at the vertex. And that is your target. And so how does it work? Well, it's a non-invasive method. Certainly, it doesn't involve anything else other than nervous stimulation. And it stimulates these bilateral nerves. And in doing so, it sends these signals to the central nervous system, modulating our ability to process pain, in turn reducing it. So specifically, we've been able to actually visualize what they do through functional MRI. There was a study in 2017 by Russo et al. That demonstrated that the use of an external trigeminal nerve stimulator actually reduced the activation of an area of the brain called the anterior cingulate cortex. This part of your brain essentially is responsible for the emotional regulation of pain. It's located in that limbic system. And so with the use of this device, it down-regulated or downplayed the activation of that part of the brain, which, proves that stimulating peripheral nerves responsible for headache modulates central nervous system pathways for headache. And this reduction in activation of the anterior cingulate cortex also correlated with a reduction in the person's perception of pain, and basically the behavioral, let's say, relationship with pain as well. And so that is the theory behind how this works. The application, which I'm actually going to do a live demo for you of both devices today, is worn with an adhesive electrode strip affixed to the forehead. So it's just going to place an electrode here, you attach the device here, and it provides that stimulation. And each one of these devices, so Cephaly and Hedaterm, are rechargeable using their proprietary, it's actually not proprietary, one is USB-C and the other one's using, I think it's USB-A for charging. And so in Health Canada cleared Cephaly for acute only, and preventatively both Cephaly and the Hedaterm device for episodic migraine and those over the age of 18. Now, does it mean that you cannot use it if you have chronic migraine? No, but the studies did not include patients with chronic migraine, nor were there any robust studies or adequate studies showing people under the age of 18. So what are the usage protocols? Well, when you're trying to use one of these devices, you have an acute mode if you have Cephaly versus a preventative mode in Cephaly, and preventative mode only in Hedaterm. So for the acute treatment, you're going to apply over the middle of your forehead for 60 minutes. I'm not going to do that today because certainly it'll be a long night for everybody. But preventative treatment, you can apply 20 minutes daily for Cephaly at the onset of your migraine attack, and 60 minutes daily for the Hedaterm with similar approach. when you look at the key trial findings for preventative, there was only one trial, which was the premise trial. This was a very small trial. So whenever you look at research trials, you want to see how many subjects are included because it adds to the power, the statistical power of these trials. Now it's 67 people. It's not the most powerful trial, but they did their best. They did a double-blind randomized sham-controlled trial. So how do you may ask yourself, well, how do you sham control a device that stimulates? Well, the sham control actually provided a very minute stimulation. So it kind of confounded the results a little bit of the sham group. However, the ETNS cohort had a statistically significant reduction in mean number of monthly migraine days compared to the sham. And so the 50% responder rate, so this is a marker of how well this works. So at the end of their study timeline, how many patients or how many subjects had a 50% reduction in their mean number of monthly migraine days? Well, in the VRUM referring to the active group, 38.1% had a reduction compared to the sham group, which was 12.1. So that was statistically meaningful. And so hence why the preventative indication encephaly. With the acute treatment trials, there was the ACME trial, which had 106 subjects, and the TEAM trial as well. So the ACME trial was randomized, double-blind, sham-controlled, and showed that the effect was stronger with ETNS, 59% pain relief, not pain freedom, so pain relief compared to sham group, which had 30% pain relief. Now, the study that Head-A-Term 2 uses is one that they did in the emergency department. It found that after 60 minutes of treatment, the Head-A-Term device actually reduced pain by 59% compared to the other treatment groups. So the other treatment groups were standard of care, which included acetaminophen, ibuprofen, naproxen, but they didn't use triptans or gepants. So they compared it to non-migraine specific options. But still, nonetheless, it performed better than those. And so when you think about the side effects, or when you look at the side effects with these medications, forehead paresthesias, meaning tingling, headache, reversible forehead skin irritation, allergic skin irritation is rare, but minor adverse events overall. And so some people may have lingering paresthesias. I don't know if you've ever used it before, but sometimes lingering afterwards, it could be quite, you can feel the stimulation just present there for a little bit of time afterwards, but it generally goes away. And who should you not use it in? Well, you shouldn't use it in people with facial trauma. If you have a clear fracture of the skull, bleeding over the area, you put the electrode, just common sense things. We'd avoid it in people with metallic head implants, intracardiac lines or pacemaker devices, anything that has any potential for electrical conduction where the electrode would go. So here we go. I didn't think I would act like a influencer today, but we're going to do a unboxing of Head-A-Term Connected, or Head-A-Term 2 and Encephaly Connected. So I provided these QR codes for you, so you can follow along if you like. So we're going to start with the Head-A-Term. So when you receive it, you're actually going to get a little package like this. In the package, you're going to see the following. Ta-da, there it is, right here. It's a little device like this that's going to provide an electrical impulse. So the first thing you're going to do, what they instruct you to do, is wash your head. You're going to wash your head with, or wash the area that you're going to place the electrode with soap and water. Make sure it's dry. And then once it's dried, you're going to place the electrode just above the eyebrows. So I'm going to show you how to do that. You're going to get them in this little packet here. And live demos. Okay, so this is what the electrode looks like. Okay, you can see there's little 2 electrode attachment points there, and it's on this backing here for the sticky components. So the electrodes are reusable. So they recommend that you keep it attached to this area and in a sealed compartment that you receive to make sure it lasts long. So you want to put it right above your eyebrows. I'm going to see if I can do this here. Right there. Don't put it too low or too high because you're going to miss out on the on the supraorbital and supratrochlear nerves. So once you have that device on, you're going to turn on your Head-A-Term. Make sure it's fully charged. It's going to have a light on. This is a demo device, so it's not active. But once you're ready, you're going to place it right on there and actually latches on. It sits there. For comfort, they actually provide a device here that you can place it over. Let's see. Failed demo. But what you can do, you can loosen it up, and this is a headband just to keep it in place. But generally, it can hold in place pretty well as long as you're not moving. And then you activate it, and then by pressing the button, it will turn on automatically the acute mode. And essentially, you leave it there for about 60 minutes. There is a graded intensity, so the more you press, the higher the intensity will go. So it doesn't memorize your intensity. So you do have to increase it to the appropriate intensity per session. So that's why this device is more cost effective, because it doesn't have that sophistication that Cephali does, but it does pretty much the same thing. And it's pretty straightforward and user friendly. So once you're done, you press the button to turn it off, remove the electrode, or remove it from the electrode. Place it back in your device, and then you're going to take off your electrode here, and then you are good to go. So I would recommend that you place it back on the sticky component and seal it up. Sealed and stored. Okay, so that's head of term. Pretty straightforward. A lot more details and video demonstrations for you on their website. The next thing we're going to do is Cephali Connected. So this one is, it seems a little bit more, let's say, technologically robust. It has a Bluetooth attachment tool and app. And so once again, similarly, you're going to clean your skin, soap and water, dry it off, pull out the electrodes that you get from Cephali. Peel off the electrodes similarly to what you did before. Place it just above the eyebrows. And then here's the Cephali device. You're going to press it. You're going to get that blue light shining up. It's going to attach to the electrodes. There we go. Excellent. And then you're going to open up. Somebody's going to take a photo of this and post it somewhere. I look interesting. So you're going to download the CC app, the Cephali app. And then you're going to press on, there's a button here that tells you to start the process, and it gives you a play, stabilize, or ramp up button. So I'm going to hold the button here, get it active. Let me see if it, well, if it doesn't work, that's okay, folks. You'll just believe me when I say it works. So this is a live demo for you. So that's what it looks like. So it comes with an app. The app can give you direction on play, stabilize, ramp up, ramp down. So that's where that sort of technologically robustness comes from for Cephali and why it's probably more expensive. The app itself also has a tracker for migraine, telling you how intense each session was. So there's a little bit more, let's say, technologic sophistication associated with it. Also a calendar, etc., in the app for migraine tracking. I just realized it's actually stimulating my head right now, so I can feel it. But I'm going to turn it off by pressing the button again, removing it. Does a little noise to recognize that it's off. Remove the sticky component and put it back in its case. So there you go. That's a live demo of both the head of term and Cephali. Pretty straightforward for you. But I won't belabor it too long because we got some more stuff to talk about. But hopefully that provided some insights on how to use this. It could be pretty straightforward if you have it all ready to go preset. So I would recommend before you try it for the first time, especially when you're in the throes of a migraine, I'd recommend setting it up ahead of time so you're familiar with the device. It's how it functions. Pre-charge it, and always make sure to wash and clean the area that you're putting the electrode on to maximize its benefit. So hopefully that was helpful and insightful for you. Cost. This is where, things are challenging because they're exceedingly expensive. The Cephali connected device, the one I showed you, has a bundle, has a device plus the electrodes, upwards of $640. There's the electrode 3-pack. So if you want to replace your electrodes, you have a standard electrode and a hypoallergenic one for sensitive skin, and they have different prices there. So standard $36, the hypoallergenic one is $50. It's optional, you don't absolutely need it, but certainly those for sensitive skin are probably important. And the head of term 2, the starter bundle, which is one device and 3 electrodes, is approximately $150. So the barrier to entry for the head of term is much better. And what's unique about it is it's designed in Canada. All right, so the company's out of BC, which is kind of cool. But yes, you can see the sophistication in terms of technology differs between cephalate and head of term. But when it comes down to it, in terms of how effective one is versus another, we can't actually comment because they've never been studied head to head. But I can say that the device technology is approximately the same, just cephalate has that Bluetooth device sophistication associated with it, which makes it more expensive, you know, that premium feel, however you want to market it per se. But the head of term 2 can provide a similar mechanism and has a little bit more, let's say, cost-effective aspect to it. Now, is there a trick to getting it covered? Well, if your insurance company has coverage for TENS machines, I would highly recommend that you get a prescription from your provider that says this is a TENS machine for migraine, and you can probably get coverage through either a healthcare spending account or some of the more advanced insurance companies may cover TENS devices. Generally speaking, you don't need a prescription for this. You can go, whether or not you've ever seen a neurologist in your life for your migraines, you can go and purchase this online without any other physician prescription. Now, the last device available in Canada is called the non-invasive vagal nerve stimulator. This is really cool technology, very sophisticated technology in terms of its mechanism, but the device itself is relatively straightforward tech. It's classified as a stimulator of the vagus nerve. Vagus nerve has garnered a lot of popularity these days for many different conditions, probably because it has a billion different physiologic purposes in the human body. But all of that to say, does it work to reduce migraine? And seemingly it does. So when you stimulate it using this device called GammaCore Sapphire, this is approved by Health Canada, a licensed medical device, it stimulates these what we call afferent signals, the vagal A and vagal B fibers that project to the nucleus tractus solitarius. So what is this NTS nucleus? Well, it's responsible for modulating different parts of the brain. In this sort of cartoon that you see on your right here, you can see that the NTS communicates with something called the superior salivatory nucleus, which then modulates the sphenopalatine ganglion, or the SPG, which is responsible for a lot of the autonomic symptoms that you see in migraine, like the congestion, the eye redness. Sometimes you can get tearing and different autonomic symptoms associated with migraine, and even trigeminal autonomic cephalalgias, which are a group of headache disorders that I'll talk about in a moment. But it also talks to the TCC, which is the trigeminal cervical complex. This is a conduit of neurons that's responsible for connecting your neck to your head. And so the nerves that are responsible for pain in your neck actually communicate inadvertently through this trigeminal cervical complex into the trigeminal nucleus caudalis, which is the epicenter of where migraine generally occurs. And so by stimulating the vagus nerve, you downregulate or modulate all of these different areas of the brain, in turn reducing migraine. It's also shown to reduce cortical spreading depression / depolarization. So this CSD phenomenon is the one responsible for migraine with aura. And so the application of handheld stimulators, the application method is as follows. The handheld stimulator placed on the anterolateral neck, which I'll show you in a moment, of the cervical branch or the cervical section of the vagus nerve. So cervical means your neck, vagus nerve descends through there, and each stimulation will last 2 minutes. And so when you look at the indications in Canada, acute and preventative treatment is approved for migraine and cluster headache. And it's prescription only, which I'll give you a QR code in a moment. And the FDA cleared in the US for adults and adolescents, but not in Canada. So for acute migraine dosing, what you want to do is a 2-2-minute stimulation. Say that 2 minutes, 2 many times fast. There you go. 2-2-minute stimulations at the headache onset may repeat twice at 20 minutes and 2 hours, up to 24 stimulations per day. And for preventative dosing, you want to do 2-2-minute stimulations 3 times a day, every day. So we're going to do a quick video demo. I'll walk you through it in a speedy fashion here. So this is from the GammaCore YouTube page.
Welcome.
And what I'm going to show you here is what it looks like to use. So that's the GammaCore Sapphire device. It basically a device that will stimulate the cervical portion of the vagus nerve, as I mentioned, and it'll go through the steps here for you. So you want to find the right area. What you want to do is find your carotid pulse. That's the pulse of your carotid artery in your neck. The vagus nerve runs in tandem with that. So once you find that pulse, you know where you're going to place your device. I don't have a demo device because I didn't provide one, but this should be sufficient. So you're going to place it in a vertical manner where both electrodes are along the carotid pulse, which in turn should be where the vagus nerve is, and you're going to practice. And so once you're comfortable where the location is, you're going to move on to step 2. Step 2 is putting on this gel-like device, gel-like substance, which you'll get supplied from gammaCore, onto both electrodes. And so once that gel is applied, you're going to turn it on by pressing the button on the gammaCore device. It's going to give you 3 numbers. The numbers are going to be as follows. It's going to give you the number of days in the month remaining, how many stimulations you have in that day, and what's the stimulation intensity. So the next thing you're going to do is now place it in the vertical manner right across your carotid pulse where you found where your vagus nerve is. And then for proper stimulation, you're going to notice the following. So step 3 is going to activate it. So once you're in the right area, you're going to start pressing on buttons along the gamma cord. You're going to hold down the top button until you feel a tingling, vibrating sensation. What's going to happen is your face is going to get pulled. It's going to feel tingling. Your facial muscles are going to get pulled, and you're going to know you're at the right level when that happens. And you're going to feel a strong impulse, and your face is going to pull a little bit, and that's when you know you got to stop. That's probably the ideal intensity for you. You don't want to use the number on the device to dictate your intensity. Use the sensation you feel. So you can see the facial pulling there. It shouldn't be super intense, but slightly, so don't be scared if it happens. And then after the 2-minute stimulation happens, you're going to hear a noise. It's going to be a beep. It's going to tell you that the stimulation is done. You're going to remove it. You're going to wait for it to recharge. You're going to wait 2 minutes between your stimulations. So you're going to place the gel on again, and then go ahead and do one more stimulation of 2 minutes. Once that's done, you're going to turn it off with a button and clean off your electrode points there, and that's it. That's gammaCore in a nutshell for you. So pretty straightforward, but I'll talk to you about why there's a big but here. Essentially, the price. But when you look at key clinical evidence, it actually performs quite well. Pain freedom at 30 minutes using there was a trial called the Presto trial. So the pain freedom at 30 minutes for the Presto trial demonstrated that 12.7% of people using the vagal nerve stimulator were able to get pain free in 30 minutes versus the sham group. The premium trial did not reach its primary endpoint. They did what's called a post hoc analysis where they broke it down into a subgroup of people who were reliably using the vagal stimulator regularly, and they found a benefit in those users, but we can't use that trial for hard evidence because it didn't reach its primary endpoint. But they repeated the trial called the Premium 2 trial, and what they found was individuals who had a reduction in their migraine days by 50% or more were approximately 45% in the vagal nerve group and approximately 27% in the sham group. And so showed statistically that this does work for those looking to have migraine relief. So what are the adverse effects? Well, you can get some neck redness, tingling, paresthesias, discomfort, muscle twitching or dizziness afterwards because you're activating that vagus nerve. And who should not use this? Well, anybody with implantable devices, pacemakers, defibrillators, anybody with carotid atherosclerosis disease. So if you're providing a stimulation to the carotid artery or in that vicinity and they have like cholesterol buildup in those carotid arteries, there's a chance that you can get emboli, microemboli as a result of stimulating that area too vigorously. Anybody who's had a cervical vagotomy, right? If the vagus nerve is not there, then there's no point in stimulating that area. Anybody with cardiac arrhythmias, metal implants, etc. So why is it that probably only one person in my practice has this? Is because of the cost. The 93-day starter kit is $750 Canadian, and your 93-day refill kit is another $750, and your 36-month kit can be upwards of $7,500. And this is all from the gammaCore prescription, the website. And this is from their prescription, which I've provided a QR code here so that you can provide to your providers. If you feel like this is something that you can do financially, then and by all means, go ahead and fill it out. But it is quite costly. You know, $7,000 a year is basically the same price as a monoclonal antibody or any of the anti-CGRP blockers. So coverage and access is limited to a prescription. So you do need to have a provider send a prescription, which I also mentioned here is provided in the QR code. And it may be eligible under very good private insurance plans. Honestly, I haven't really seen it being covered, but it's possible. Worth a try if you feel like you're a good candidate for this. Now, this is not a cluster headache talk, but I should mention that Health Canada approves the non-invasive vagal nerve stimulator for both acute treatment of cluster headache and preventative treatment of episodic and chronic cluster headache. And so the summary here is as follows. When you try and use the acute mode for episodic cluster headache, it's a similar to 2-minute stimulations immediately at the attack onset. And there was the Act 1 and Act 2 trials that demonstrated statistical significant benefit with this medication, with this treatment. And then when it comes to the preventative modes, you're going to use 2-minute stimulation administered 3 times a day or twice a day as preventative maintenance. And this was through the PREVA trial that they demonstrated benefit in this cohort. Interestingly, we're entering C, there's no maple leaf here. So this is not Health Canada, but an FDA cleared this device for paroxysmal hemicrania. So this is one of the other primary headache disorders in that trigeminal autonomic cephalalgia family, based solely on a case series. So remember, a case series is a very weak data, but it was good enough to the FDA to say, okay, fine, we'll essentially approve this for paroxysmal hemicrania because there's nothing else out there. So let's help these folks. Now, I want to talk about some of the devices not available in Canada now. So we finished all the devices available in Canada. Happy to answer questions more about those at the end of today's session, but let's go through what else is available, and hopefully, on my fingers crossed, especially this one, will be available in Canada in the near future. So Neurivio, also called the remote electrical neuromodulation device, basically is this really cool technology that activates A delta and C fibers. These are specific neurons and axons of pain. So A delta is fast pain, C fibers are slow, gnawing pain. And so what this arm device does is it actually stimulates the pain nerves in your arm, but it stimulates it to a point before it actually becomes perceivably painful. And so it sends what's called these sort of potentials through these nerves that don't reach depolarization threshold, but then they actually activate these descending pain pathways, resulting in an anti-pain effect all over. So once again, you're stimulating the peripheral nervous system, these pain nerve cells in your arm, to then communicate with your central nervous system, to then send descending anti-nociceptive signaling downwards throughout the rest of the body and through the trigeminal system to reduce pain. So it's really cool technology, and the FDA cleared it in the United States for both acute and preventative treatment of migraine in patients aged 12 years and older, and not currently approved in Health Canada as of yet. The acute use protocol uses a 45-minute session initiated at migraine onset, can be repeated as needed. And for preventative protocol, 45-minute sessions administered every other day for prophylaxis. So we talked about the evidence here. So pain freedom at 2 hours using this device compared to a sham group showed 37.4% pain freedom in those who used the device versus 18.4% in the sham group, and pain relief and double that, so 66% versus 38% in the sham group. Mind you, the sham group did have a slight stimulation, so whether or not that actually provided them some benefit, that hence why the sham group is so large, it's yet to be seen. But we see a lot of high placebo responses in migraine treatment, in migraine trials in general. So the preventative data is based off this randomized controlled trial performed by Dr. Tepper and al. Significant reduction in monthly migraine days for both episodic and chronic migraine. So the safety profile, super well tolerated. Mild effects use warmth, tingling, transient stimulation at the site, discomfort. And what's even more important is that they actually published in 2023 a survey of 140 women with migraine who used REN during pregnancies and others who did not. And retrospectively, they found that individuals who used the REN during pregnancy did not have any differences between gestational age of their child, miscarriages, preterm birth defects, stillbirths, or newborn outcomes at 3 months, meaning this retrospective data does suggest that it's safe in pregnancy, which is phenomenal. And then we don't want to use this in people with congestive heart failure, active implantable medical devices, pacemakers, cochlear implants, just because we have no idea if these electrical impulses can interfere with those devices. So that's the REN device, not available in Canada, but hopefully soon. Let's talk about single pulse transcranial magnetic stimulation, so TMS or STMS. The device here is called eNeura, once again not available in Canada. However, it's been studied in both acute and preventative migraine treatment. What it does is it provides this 10 hertz magnetic stimulation primarily over either the left motor cortex or other sites like the left dorsolateral prefrontal cortex and the vertex. In theory here, these areas, the precise mechanisms are still haven't been elucidated, but they found that these two areas, if stimulated, can provide some pain relief. With the acute data, there was one blinded sham-controlled RCT, 201 subjects, so pretty decent numbers, with migraine with aura showing significant benefit on what's called the International Headache Society endpoints, which were which I won't go into today, but those are endpoints used in a lot of European trials. They can include things like pain freedom at 2 hours for acute, reduction in monthly migraine for preventative outcomes. So for preventative trials, 10 studies, cohort of subjects, 416 of them, 5 blinded, 8 sham controlled, also showed some benefit. And so when you look at the efficacy overall in the guidelines, there hasn't been really any consensus on whether or not this is effective. There's been a lot of heterogeneity between the research trials. And for the most part, this technology has been really, really important in mental health and depression. And so the way to access it won't be through a migraine indication in Canada. It would be through depression. Now, if that inadvertently helps your migraine, certainly that could be an argument to be had about improvement of depression, how that helps with migraine. But the protocols they use for depression are different than migraine. For the most part, a lot of this single pulse transcranial magnetic stimulation is still in its infancy. And so I'm hopeful that in the future we'll be able to see more of this inside of the OHIP or sort of the Canada public healthcare system approval, but we still need more data to be accumulated. It's just too messy right now when it comes to evidence. But overall, adverse effects are very mild in general with a lot of these studies. Scalp discomfort, most common transient drowsiness, is rare but reported. And we don't want to use it in people with cardiac disease, epilepsy, and once again, long-term safety is unknown. I've used this device at one of the conferences. It feels like you're getting this almost like a little tap in the back of your head because it sort of shakes that device without sending that magnetic impulse. So it can certainly be quite uncomfortable for people with allodynia, for example. The last device that I'll go into detail with here is called the combined occipital and trigeminal neurostimulator. The brand name is called Relivion. It's a non-invasive headband which delivers electrical stimulation into the trigeminal nerves, and then it wraps around, it goes to your occiput and also provides stimulation there. So the targets are the same nerves that you use for ETNS, which are supraorbital, supratrochlear, but you're also getting the greater occipital nerves. And so these electrodes in the back are using water moistened sponge electrodes. And so that's where the signal is being delivered through. And so why do we want to stimulate the occipital nerves? Remember, I talked to you about this trigeminal cervical complex. It's this conduit of neurons that connect your upper cervical sensory nerves to your trigeminal nerves. Well, that's what it's targeting. And it's modulating the migraine at 2 levels, the trigeminal nerve level and the upper cervical plexus. And the upper cervical sensory neurons. So it's a dual pathway stimulation. It also enhances neuromodulatory effects through just stimulating those 2 nerve pathways. And it's FDA cleared, so cleared in the States for acute treatment of migraine in adults. Once again, not approved in Health Canada. So how the usage protocol goes, for acute management, they use this for 45 to 60 minutes at the migraine onset. And then for prevention, about 20-minute sessions once daily. This is an optional. It's not approved through FDA for prevention as of yet, just due to the minimal evidence available, but for acute, it is approved. And the key acute trial was the RIME trial, the RIME trial. So it was a randomized sham-controlled, 131 subjects. So those who used the combined OTN found that pain freedom at 2 hours was in 46% in the treatment group, and then 11.8 or approximately 12% in the sham group, which is pretty significant therapeutic gain there. The reduction in most bothersome symptoms. So you're going to see this sometimes if you read migraine research. Most bothersome symptom can be headache, but it can also be nausea, it could be phonophobia. And so they found that people used the combined OTN, found that MBS freedom was 75% in the active group and about 47% in the sham group, and then full symptom freedom in about 47% in the active group and then 11% in the sham group. So pretty significant therapeutic gain if we're looking at the stats, just at the stats from this trial. And the preventative data is just open label extension, so not really robust data, it's pretty weak data, but showing a signal that this could potentially be helpful in prevention. So it just needs to be studied better. Safety profile, mild, localized adverse events, skin irritation, discomfort, and no increase versus sham. And once again, common sense dictates you don't want to use this in active implantable devices, pacemakers, defibrillators, metallic head or neck implants. This was a special request. Somebody had asked that we talk about invasive occipital nerve stimulation because there was a point in time, I think, in the last decade or so where this was being used quite often. And it's, certainly you're going to see some folks advertise this as an option. It's a surgical implantation of electrical leads, as you can see here, underneath the skin at the cranial cervical junction, so where the skull meets the neck, positioned over the occipital nerves. It will stimulate the occipital afferents, so the nerves signaling inside the brain, to modulate pain transmission in once again, the TCC, the trigeminal cervical complex, and central network. So it's providing an invasive way to stimulate the occipital nerves directly to influence that TCC as well as modulate pain centrally. So there was a large meta-analysis showed that had pretty substantial preventative effects with about 3 fewer headache days per month versus sham. So the people who were enrolled in the study had 3 less headache days per month versus the sham group, which was an implantable stimulator that did not stimulate. In the 3 key randomized control trials, 1 was negative for its primary outcome, but positive for secondary endpoints. And the other 2 were positive overall. So you're seeing this mixed data. So that's one red flag. Limitations or heterogeneity. So what does that mean? Basically means that these studies were not cohesive. There was no basically similarities on how they approached. The methodology was different. And so the most important thing here, and I highlighted it, is the high complication rates. These leads can migrate, you can get infections, and certainly right now it's reserved for very, very refractory chronic migraine in select research or specialized contexts. You don't want to go to just anyone who's advertising this. You want to go to these comprehensive clinics who've done this many, many times just due to its delicateness. So let's talk about emergent and experimental neuromodulation therapies. I feel like you're going to see some of these very soon. Some of them look very unusual to say the least, but I believe some of them have a lot of merit. So the transcranial direct current stimulation delivers a low current stimulation over the cortical targets, once again, the M1 and the dorsolateral prefrontal cortex, to alter excitability. So it just downregulates that excitability of the brain. Mixed, weak evidence, some preventative benefit, but right now they're non-blinded studies, so we're going to see how this goes over time. So it's basically doing the RTMS thing, but with direct current stimulation. So you can see it's like almost putting electrodes in certain areas over the head and then providing electrical stimulation there. So it's not magnetic. The next one is kinetic oscillation stimulation. This is a oscillating nasal balloon catheter. They advertise it by sticking it into the nose, inflating it, deflating it by stimulating the trigeminal afferents to modulate central pain pathways, almost like and activating what's called the gate theory of pain, where if you provide an alternate stimulus to the trigeminal system that's non-noxious, or at least a different form of a noxious stimuli, it can then downplay or at least downregulate the amount of pain you may feel from your migraine. Now, they did perform randomized controlled trials for both acute and preventative migraine. Though in the preventative group, they may have had 3.5 less migraine days compared to 1.2 in the sham group. But once again, it's a small trial. The power of these trials is quite low, and so there's still research to be done before its prime time use. Now, I feel like this one is going to be something we're going to see very soon, is auricular transcutaneous vagal nerve stimulation. People use this in Europe quite a bit. I have a couple of my patients who have epilepsy who've had this device where they place this ear-based vagal nerve stimulator. It targets the left auricular branch of the vagal nerve. And vagal brainstem circuits are the end goal for that. And so it's early data, small RCTs showed reduction in headache days, but there's no FDA or Health Canada approval yet. So you can actually purchase this from Germany or other places. But certainly right now, just because of the limited data, Health Canada has not approved it. So we're almost done today, but I want to go through the challenges with non-invasive neuromodulation. So economic and access barriers are always a problem when it comes to migraine management. High out-of-pocket costs. You saw some of the costs that I quoted here today. Devices are expensive, limited or no insurance coverage. So this alienates a lot of folks and causes an inequity of access to migraine care. Reimbursement gaps. Most payers still classify these neuromodulators as experimental, so it's limiting accessibility. They are not, there are some devices, as we talked about, like the REN device and the combined occipital trigeminal nerve stimulator device are not approved or distributed in Canada yet. So there are some limitations in availability of some really cool devices. And then the cost effectiveness is questionable. Like economic analyses suggest poor value at current pricing. And so there was this big study actually published, I think, this year in May by some of my colleagues, and they looked at the vagal nerve stimulator, specifically in cluster headache, but in certain individuals, it just didn't, the math didn't work out. Specifically with migraine prevention. In cluster prevention, it did work out. The actual justification for the costs panned out. But when it came to looking at what's called the ICER, which is the amount of money needed to provide a person with 1 year of a good quality of life, just didn't work out at the end of the day. But this was specific to the vagal nerve stimulator. So it just shows that some of these companies probably need to maybe alter their pricing or at least make it more accessible for most folks. And the evidence and research limitations are still there. There are short-term studies, there's small studies, poorly powered studies, there's a lack of methodological variability, or there's high degree rather of methodological variability. And so we need a cohesive approach to performing these research trials with these devices, which is yet to be done. And our migraine trials are pretty bang on equivalent methodologically speaking, but there's still some variability here. The certainty of evidence is inconsistent or at least poorly powered, like I mentioned, due to the small sample size and understudied populations, special groups, pregnant patients, cardiovascular disease, under age of 18, older populations, people with chronic migraine. These are big population groups that need studies to be done for these devices. And so this was a table I put together looking at how do these devices compare to migraine medications? And I'm going to explain this to you if you're not familiar with some of the stat terms. So on the top here, we have non-invasive neuromodulation. So everything I talked about today. Triptans and Gepants. All right, triptans are our go-to for acute specific migraine acute treatment, and then Gepants are our new tools in the toolbox for acute treatment. We looked specifically at sumatriptan, rizatriptan, elatriptan for triptans. Gepants were Migepant, Ubrogepant, and then the devices I mentioned here. And so when you look at specifically the number needed to treat to achieve pain freedom, the non-invasive neuromodulation devices, despite their poorly powered studies, had a number needed to treat, meaning how many people do I need to try this on for one person to have a meaningful outcome or good outcome or pain freedom? It was about 9 to 14, 6 to 7 in triptans, and 9 to 13 in Gepants. So triptans we know work really well, but they're limited by their cardiovascular risk, medication overuse risk, and harm. So I didn't put this in here, but I'm gonna give you the numbers for the contrast on the number needed to harm. So number needed to harm is essentially how many individuals need to receive this treatment to have a meaningful adverse effect or be harmed by it. And so the number needed to harm for Gepants is greater than 50. So Gepants are like super well tolerated. The number needed to treat here certainly is high, but also keep in mind that we're looking at 2-hour pain freedom. And a lot of these studies for Gepants told the patients to take the Gepant at moderate to severe pain. And if you've ever received the Gepant, you know your provider said treat at mild headache. And so that number should be higher. And I would imagine the number needed to treat if Gepants were given at a mild headache would be lower than this. But all of that to say, the number needed to harm for Gepants is greater than 50, so very well tolerated. For triptans, it's 5 to 10. So essentially, for every 10 people who use a triptan, one person is going to have a meaningful adverse event. And then for the non-invasive stimulators, it's essentially 29 in the ETNS group, but greater than 100 in the vagal nerve stimulator group. So very well tolerated, even though the number to treat is quite high. So it just goes to show that these are equally, players in the acute toolbox, even though the data I think is weaker compared to triptans and gpans, but because of how safe they are, I think everybody should be offered them. So I'm going to do 3 quick cases just to show the applicability of these devices in day-to-day practice for providers. So the first case, we have a 38-year-old woman with episodic migraine without aura, about 6 to 8 days a month. She's tried multiple acute medications, triptans, NSAIDs, gpans, sounds familiar, with minimal relief and side effects, right? This is a very common scenario that we see in our day-to-day practice. She wants a non-drug option she can use for both acute and preventative treatment of migraine. So think to yourself, after I talked your ear off now on all these devices, what non-invasive treatment would you choose for her? So in this instance, I would choose one of the external trigeminal nerve stimulators. One, it's approved for episodic migraine, also for acute management in cephaly and head of term, but preventatively also in the cephaly device. Sorry, the other way around, cephaly for acute and preventative, and head of term 2 for just for preventative. So either one of these options are great for this individual, and we know that they're very well tolerated. So the second case here is a 45-year-old man with episodic migraine with aura actually, 5 migraine days per month, but he has hypertension, acid reflux, can't use triptans or NSAIDs due to his high blood pressure, and NSAIDs because of his acid reflux. He looks for a rapid-acting portable therapy without systemic effects. He's on the go, he's working, he's trying to, just work through the migraines on a weekly basis. What would you recommend as an acute or adjunctive option? Well, in this instance, probably the vagal nerve stimulator, right? This might be a good option primarily because of its benefit in aura. So cost aside, this is the only device that has been shown to reduce cortical spreading depolarization. And so this would be a good option for this individual, especially with the aura history. And lastly, we have a 30-year-old woman in her 2nd trimester with migraine without aura. We educate our patients that as 2nd and 3rd trimester start to come along, generally migraines improve, but what if they don't? Well, she stopped her usual triptans and beta blockers due to pregnancy, so that's, a common scenario. But she wants safe, non-pharmacologic options for acute and preventative control. So what are we going to offer? Well, the TENS device, or sort of the ETNS, so cephaly or head of term, or if available, the REN. So if this individual has access to the REN device, that's the only one that had some pregnancy data to advertise, even though it was a retrospective questionnaire study. So it wasn't the strongest of evidence, but it was still evidence to some degree suggesting that it's safe in pregnancy. So to recap, I hope at the end of this talk, you're able to now understand what neuromodulation is and how it helps manage migraine. I hope now that you can recognize the main types of different neuromodulation devices, and I hope that you've learned which devices are currently available in Canada, how to access them. At this time, whether or not this is a good option for you, you can sort of at least have a flavor of what's out there, and you can talk to your provider about what would be right for you, and know what to expect in terms of treatment process, costs, especially, and support. And you also saw a live demo of me trying to place these devices on on myself as well. So I'll end today with a quote that's inspired by William Gowers, who sort of put together 2 and 2 about the neurocircuitry and neurology, and I put together this quote saying that the brain circuits can be our therapy, not just our target. And so at this time, I will end the talk. Thank you, everybody.